Welcome to the Vet and Crit Academy, where we discuss veterinary emergency and critical care and science-based tools for veterinary professionals. Today, we'll explore a fascinating and challenging case of a traumatic brain injury in a kitten, complicated by hypernatremia or elevated sodium concentration and hyperglycemia or high blood glucose. I'm Igor Yakin, a board-certified ECC specialist, and I'll be walking you through Boris's journey. Boris is a 6-month-old intact male kitten who was presented to the emergency service for evaluation after he was kicked by a goat approximately 4 hours prior to presentation. According to the owner, Boris was initially able to run out of the way, but then was found on the ground not moving. Boris was immediately taken to his primary veterinarian for evaluation. At the vet's office, he was open-mouth breathing, had a moderate nasal bleeding, was ambulatory tetraplegic, and had a mesochoria characterized by mydriasis of the right eye with sluggish pupillary light response. Also, he had instability of his lower jaw and teeth fractures. Boris was given buprenorphine with midazolam for a set of radiographs and was sent to the referral facility. The radiograph taken at his primary veterinarian showed unstructured interstitial lung pattern in the cranioventral lung lobes and sternum relaxation. In addition, there was a moderate gas distension of the stomach, most likely secondary to his dyspnea. In regards to his past history, Boris had been an otherwise healthy, happy, born kitten with no previous medical history or veterinary care. Boris was transported to the emergency service where he arrived by 11 a.m. On presentation, he was still ambulatory tetraplegic with obtunded mentation, increased respiratory rate, and effort. His body temperature was elevated at 105 Fahrenheit or 40.5 degrees Celsius. His cardiovascular parameters appeared within normal limits, and the rest of the physical examination remained unchanged compared with the initial exam. However, he appeared blind. The initial blood work showed relatively normal acid-base status, normal electrolytes, moderate hyperglycemia at 313 milligram per deciliter or 17 millimoles per liter, and high normal BUN and creatinine concentrations, as well as normal PCV and total solids. By the way, you can watch a free workshop on acid-base analysis by clicking the link below located in the description. Soon after presentation to the ER service, Boris's mental status worsened and he became non-ambulatory tetraplegic. He was given a 3 ml per kg bolus of 7.2% hypertonic saline that was repeated once a bit later due to the lack of positive response. He was kept in an oxygen cage due to his dyspnea, flail chest, and traumatic brain injury. He was started on fentanyl concentrate infusion to reduce the pain associated with multiple fractures. A dose of mannitol was given later that afternoon in an attempt to improve mentation and progressively worsen neurologic status. In the first few hours after presentation, he was kept on a maintenance rate of lactated Ringer solution since he was cardiovascular stable and there were no apparent dehydration or ongoing losses noted on his physical exam. A recheck serum sodium concentration 6 hours later showed marked hypernatremia at 186 millimoles per liter that jumped from 153 on presentation. Before I tell you how this problem was addressed, let's talk a little bit more about the mechanisms of hypernatremia. Serum sodium concentration is determined by the ratio of sodium to water in the extracellular fluid. The primary factor influencing sodium concentration is water balance. Hypernatremia typically occurs due to a loss of free water or hypotonic water combined with an inability to replace those losses by consuming water. A less common cause is an increase in sodium or solute gain such as from salt ingestion. Intense thirst is typically highly effective at preventing the development of hypernatremia. However, patients with impaired thirst mechanisms caused by metabolic or neurological disorders are much more vulnerable to hypernatremia. This is because they cannot adequately compensate for free water losses by consuming enough water. If we revisit Boris's case and consider the potential causes of his hypernatremia, the following differentials emerge. First, hypertonic saline administration. Boris received 2 boluses of hypertonic saline, which can increase sodium levels through solute gain. However, the administered dose was typical and not usually associated with such significant sodium increases in similar trauma cases. Second differential is free water losses via osmotic diuresis. The combination of hyperglycemia and mannitol administration likely caused free water losses through increased urination. Boris appeared to be polyuric, which could have contributed to his elevated sodium levels. The third differential is impaired water intake due to neurologic status. Boris's obtunded and stupor state prevented him from drinking enough water to regulate his plasma osmolarity, exacerbating his hypernatremia. The differential number 4 is post-traumatic central diabetes insipidus, or CDI. Patients with traumatic brain injury can develop CDI, which causes polyuria and free water loss due to a lack of antidiuretic hormone secretion. Now, let's spend a little bit more time on reviewing post-traumatic central diabetes insipidus, or CDI. Vasopressin is a peptide produced in a hypothalamus and secreted by the neurohypophysis in response to small increases in serum osmolarity. This results in an increased water retention by its antidiuretic effects on aquaporins in the kidney. Vasopressin can also be stimulated if there is a 10% or greater decrease in blood pressure that is sensed by atrial baroreceptors and causes non-osmotic vasopressin release and subsequent vasoconstriction. This lack of vasopressin production, secretion, or receptor dysfunction in the collecting ducts of the kidney can lead to diabetes insipidus, which causes the loss of free water through the kidneys and can lead to severe polyuria, hypostenuria, and occasional hypernatremia. The traumatic event may lead to dysfunction of the hypothalamic pituitary axis due to the direct mechanical impact or cerebral consequences of trauma, such as ischemia, hypoxia, and alterations of cerebral blood flow. The major diagnostic criteria for post-traumatic central DI include polyuria for longer than 2 hours, hypernatremia, increased serum osmolarity caused by hypernatremia, low urine osmolarity due to the lack of ADH in the circulation that is supposed to reabsorb free water from the renal tubules, and finally, a positive response to DDAVP or desmopressin administration. The challenge with diagnosis of post-traumatic DI and traumatic brain injury patients is that TBI treatment interventions such as administration of hypertonic saline and/or mannitol can complicate interpretation of sodium levels, urine output, and urine-specific gravity. Thus, response to DDAVP and/or vasopressin infusion may be a critical diagnostic step when it comes to the diagnosis of post-traumatic CDI. Since Boris's hypernatremia resolved within the first 36 to 48 hours and no urine sample was collected, we can only speculate whether he may have experienced transient post-traumatic diabetes insipidus. Post-traumatic DI is well described in human TBI patients. Prevalence of acute CDI in adults is estimated to be within 3 to 26% range according to the numerous clinical trials. It's been shown that lower Glasgow Coma Scale and cerebral edema and imaging may be an independent risk factor of developing CDI post-brain injury in people. In human patients, it's often a transient disorder that resolves within several days, weeks, or months. Since not only vasopressin release may be impaired, a routine screening for endocrine dysfunction following TBI is gaining favor in human medicine. What about the evidence of post-traumatic CDI in veterinary medicine? There are at least 5 to 10 case reports in veterinary journals documenting this pathologic disorder in both dogs and cats. In 2009 JVEC paper, they describe a dog that developed a diffuse hypothalamic pituitary axis deficiency resulting in hypoadrenocorticism, central diabetes insipidus, secondary hypothyroidism, and growth hormone deficiency. The dog was eventually euthanized. Now, let's go back to Boris and take a look at his serum sodium concentrations during the first 36 hours of hospitalization. Y-axis represents his sodium concentration and x-axis the timeline during the first 36 hours since admission. As you remember, he presented with sodium concentration of 153, which is high normal for a cat. 6 hours later, it went up to 186. Overnight, the marked hypernatremia persisted, but the healthcare team was able to bring it down in the 178-180 range with the administration of 5% dextrose as a source of free water. By 10 p.m., Boris's sodium concentration was successfully brought back to the baseline value of 155 millimoles per liter. This was accomplished by administering fresh water by an NG tube and using a continuous rate infusion of regular insulin to manage persistent hyperglycemia. As you'll remember, you do not want to cause rapid changes in sodium concentration due to high risks of causing either cerebral edema or osmotic demyelination syndrome by shifting water in and out of the neurons. The only exception to this rule is if you're absolutely sure that the patient became hypernatremic acutely, which was the case in Boris. It was noted that Boris's sodium concentration was normal at the time of presentation. Therefore, it was decided to rapidly normalize his sodium levels within 36 hours, ensuring no additional harm to his already compromised brain. While this process took 36 hours, it could have been completed more quickly within a 12-24-hour time frame. Now, let's examine Boris's blood glucose curve. One significant challenge faced by the critical care team, which partially hindered the resolution of his hypernatremia during the first night of hospitalization, was his persistent hyperglycemia ranging between 300 to 500 milligram per deciliter or 17 to 27 millimoles per liter. This level of hyperglycemia is not uncommon in patients with severe traumatic brain injury. The hyperglycemia likely contributed to free water losses through osmotic diuresis, making it difficult to resolve his hypernatremia initially. From day 2 onward, Boris received regular insulin as a continuous rate infusion, which was later transitioned to intermittent subcutaneous injections on an as-needed basis. This approach successfully maintained his blood glucose levels within the range of 150 to 300 milligram per deciliter or 8 to 16 millimoles per liter. By days 6 to 7, Boris was completely weaned off insulin. So, why does hyperglycemia occur in human and veterinary patients with severe traumatic brain injury? There are several explanations for high glucose levels after TBI, and one of the most studied is stress-induced hyperglycemia caused by upregulation of sympathetic tone. After TBI, the activation of the hypothalamic pituitary adrenal axis and the sympathetic autonomic nervous system induce elevated blood levels of numerous counterregulatory hormones, such as catecholamines, cortisol, glucagon, and growth hormone, which enhance glycogenolysis and hypermetabolism and lead to excessive glucose production and insulin resistance. On top of that, TBI is accompanied by systemic inflammatory response syndrome that may worsen hyperglycemia. Therefore, a combination of elevated sympathetic tone and inflammatory response seem to be the major causes of hyperglycemia in patients with traumatic brain injury. Another question that may be worth exploring is whether hyperglycemia in TBI patients is simply an indicator of injury severity or it directly contributes to the brain damage. Under ischemic and hypoxic conditions, hyperglycemia disrupts normal metabolism by inhibiting the tricarboxylic acid or TCA cycle and promoting anaerobic glycolysis. This leads to the accumulation of lactic acid and intracellular acidosis. Hyperglycemia also worsens endothelial cell edema, damages glial cells, and can even cause the rupture of the blood-brain barrier. As a result, intracellular acidosis and blood-brain barrier disruption ultimately lead to ischemia, edema, and necrosis. Additionally, hyperglycemia increases blood viscosity and contributes to diffuse small vessel disorders, further exacerbating ischemia and hypoxia in brain tissues. In human medicine, hyperglycemia at admission and persistence of hyperglycemia have been associated with worsened mortality and outcome. In head-injured veterinary patients, hyperglycemia has been associated with more severe injury but has not been validated as an independent predictor of outcome. The understanding that hyperglycemia is not merely a passive indicator of trauma severity, but can actively worsen brain injury has driven extensive research in human critical care to determine the most effective glycemic control strategy for TBI patients. In the early 2000s, tight glycemic control, such as 80 to 120 milligram per deciliter, 4.4 to 6.7 millimoles per liter, was widely practiced and was supported by landmark studies that demonstrated potential benefits. However, over the last decade, mounting evidence has shown that overly tight glycemic control may actually harm the injured brain. One notable study published in the Neurologic Critical Care Journal compared two glycemic control strategies, tight control versus moderate control. All patients in the study had cerebral microdialysis catheters placed, which allowed monitoring of the interstitial brain glucose and the lactate to pyruvate ratio. The results revealed that patients in the tight control group experienced significantly more frequent brain energy crises characterized by dangerously low brain glucose levels and elevated brain lactate. This metabolic imbalance contributed to higher mortality rate in the tight control group. All right, so now let's go back to Boris. During the first night, he was managed with 5% dextrose in order to correct his severe hypernatremia that was subsequently replaced by freshwater administration via a nasogastric tube due to persistent hyperglycemia. Hyperglycemia was initially treated with regular insulin CRI that was later switched to intermittent subcutaneous injections on as-needed regimen. Fentanyl CRI was used in the first 48 hours and later switched to buprenorphine. Over the first 48 hours, Boris remained non-ambulatory tetraplegic and stuporous. On day 3 after the presentation, Boris's neurologic status and mentation improved. His hypernatremia completely resolved, but he remained to have intermittent hyperglycemia that was managed with intermittent subcutaneous injections of regular insulin. On day 6, he was put under general anesthesia for esophagostomy tube placement, teeth extractions, and mandibular fracture repair. At that time, he started drinking milk on his own for the first time. He was able to walk without any ataxia and was discharged the following day. All right, so now let's talk about the takeaways. Based on some pediatric protocols for treating traumatic brain injury in children, the administration of 3% hypertonic saline is typically limited to no more than once every 12 hours. These protocols are conservative in both the dosing and concentration of hypertonic saline. In veterinary medicine, it may be prudent to apply a similar cautious approach when using 7.2% hypertonic saline especially. This is particularly important in pets that cannot drink or have additional comorbidities, as frequent administration of hypertonic saline can increase the risk of complications. In addition to managing fluid therapy, it is essential to closely monitor sodium and glucose levels in pets with moderate to severe TBI. Hypernatremia and hyperglycemia can exacerbate the injury and complicate recovery if not addressed promptly. Endocrine dysfunction, particularly involving the hypothalamic-pituitary axis, is another critical consideration in TBI patients, as trauma to the region can significantly impact treatment and prognosis. Finally, it is important to recognize that young animals, such as kittens and puppies, often show a better capacity for recovery from severe TBI compared to older animals. So don't give up on them too early. They often surprise us with their resilience. If you enjoyed this video and want to see more content like this, leave a comment below and don't forget to explore the VetMCrit channel for more. Bye-bye.